Hi, everyone. I am here to give a full lecture on acute and chronic kidney disease. So before we get started, I wanted to show you a video.
You can still enjoy the special moments. You can still enjoy the special moments in your life, even with.
Uh-oh. Where'd it go? Sorry.
You can still enjoy the special moments in your life, even with kidney disease caused by diabetes. You just have to know your kidneys. If you have kidney disease, it can lead to kidney failure. If your kidneys stop working, you'll need dialysis or a kidney transplant to stay alive. But the good news is there are actions and medicines you can take to keep your kidneys healthy, and treatments that can help control your blood pressure and diabetes. To keep your kidney disease from getting worse, you can control your blood sugar, control your blood pressure, control your cholesterol, eat healthy, quit smoking or using tobacco, be active most days of the week, and stay at a healthy weight. When you keep your blood pressure and diabetes under control, you keep your kidneys working longer and delay the need for dialysis or transplant. To learn more and download a doctor discussion guide, visit kidneyfund.org/knowyourkidneys.
So just a little initiation to thinking about acute and chronic kidney disease. So just thinking a little bit before we start talking about different causes and phases and what are we going to do about a patient that comes in with either acute or chronic kidney disease. Typically, you're going to see the symptoms are going to be very similar between both. The symptoms, the causes, the interventions are going to be very similar. It's just basically differentiating, is this an acute problem? Is this a problem because of something else that's currently going on, right? So do we have to identify what the underlying cause is to be able to determine to be able to fix this acute or short-term problem? Or is this something that we have already caused damage over a long period of time to the kidneys, in which we would identify it as chronic kidney disease? You will see a couple asterisks around this over here on diabetes, hypertension, osteodystrophy. And I did star next to the chronic kidney disease just so that you guys can kind of link those couple things together. But like I said, pretty much overall, you're going to see whether it's an acute or a chronic, it's just really differentiating, is this a short-term period or a long-term period? So our kidneys have primary structures that are important for you to just remember. We have your tubules, our glomeruli, our interstitium, and our intrarenal blood vessels. And so these all play a part into what is going on, especially when we're looking at etiologies, different phases, different causes. Sometimes medications can work on a certain area in your kidneys versus a disease or an obstruction may work on a different location. So just being familiar with the different types of structures. We can have tubular damage, which could be due to maybe some ischemia, so maybe some stress or lack of blood perfusion or renal perfusion. We can also have tubular damage from nephrotoxic agents or nephrotoxicity, more specifically things like contrast, so our patients going down for CT with contrast, maybe our patients that have rhabdo. Sometimes some medications can cause become nephrotoxic. We can have glomerular damage, which would be maybe something related to glomerular nephrosis or glomerular nephritis, which would be that infection of your glomeruli. So you may see some hematuria or proteinuria in this patient. We may see some interstitial damage. Typically, this is really going to be seen in a lot of your allergic reactions. So allergic reactions from things like penicillin, cephalosporins, your antibiotics. And then we can have vascular damage, which would be more to your macro and micro vessels. So things like hypertension, preeclampsia would be things, heart failure could be things that could damage those, the micro and macro vessels. So some different causes to acute and chronic kidney disease. heart failure and all the medications that really surround heart failure. Colon cancer, antibiotics, most all antibiotics or all of the antibiotics are filtered and metabolized through the kidneys. So again, those can become nephrotoxic. Dehydration. So again, if we're not perfusing our kidneys, we're not going to be able to allow them to work appropriately. Kind of going hand in hand with sepsis. Diabetes, if we're not controlling our blood sugar, we're going to kind of start gunking up, thinking about sugar and water. You mix them together, it becomes very sticky. That sticky substance starts to adhere to the inside of your vessels, which can cause that lack of perfusion. And then hypertension. So again, if we are constricting all the time, again, we're going to damage and limit that perfusion. These are just very generic causes. Pretty much anything you can think of could possibly put your kidneys at risk. But these are just your typical generic causes of acute or chronic kidney disease. A lot of times too, I also want to let you guys know, you may see maybe in clinical acute on chronic, and that's because, maybe this has been an acute phase for a long period of time, and we're starting to notice that that damage is actually becoming permanent. So you may see that terminology used very frequently, especially in clinical. So we have different etiology. We have pre-renal, renal, and post-renal. It's just, different reasons or causes to why we have this kidney damage. So we talked about tubular damage and glomerular damage and interstitial damage and vascular damage. These are a little bit more specific. So we have our pre-renal phase, which is where you're going to see that GFR decrease, that decreased perfusion, decreased blood flow, a lot of times because your patient has some form of dehydration. Dehydration such as vomiting, diarrhea, hemorrhage, diuresis, third spacing, decreased output, maybe increased use of diuretics like furosemide. So this would really fall into that pre-renal cause. You may see this relating to burns. The renal phase you would see that increase of concentration of the urine. So kind of like we were talking about with the nephrotic syndrome and the glomerular nephritis, you're going to see that hematuria, that proteinuria, you're going to see a higher concentration of something in your urine. A lot of times you're seeing this with inflammation, toxicity of medications, too much of the medication. And then post-renal causes would be some form of an obstruction. So BPH, prostate cancer, maybe some stones. This is a great picture just to kind of show you again what we were talking about. So pre-renal, that hypovolemic phase. So you're dehydrated, you maybe have heart failure, so you're not getting that perfusion adequately to your kidneys. Intrarenal or renal, they go hand in hand. They're really used, those words are used simultaneously. Any sort of medications or inflammation. So that's why you're seeing here the glomerular disease, the tubulointerstitial disease, nephritis down at the bottom. So again, maybe they have nephrotic syndrome and you're seeing proteinuria, low albumin, edema, hypertension, due to the fact that your molecules are basically just passing through and they're not being metabolized or utilized at all. And then over here on the right, so our post-renal, like I said, usually some form of an obstruction, maybe a UTI, maybe some medications, BPH, but a lot of times just so you can start to categorize, what is the cause and what is actually happening with this patient that has kidney injury, more specifically acute kidney injury. And then moving down, so there are different phases. I'm going to kind of go back to the picture first. There are different phases. If I highlight it down here, we have different phases of our acute kidney disease. Right, so we have our onset of symptoms, we have our oliguric, and these might not be new, these may be familiar terms, you just may not have visited them recently. We have our onset, our oliguric, anuric, our diuretic phase, and our recovery phase. So we start here, number 1, number 2, number 3, and number 4. So our onset hours to days, right? So when is this starting? Sometimes you may not even see those symptoms during that onset period. So you may just see some decrease in urine output, but you're not necessarily going to see any significant symptoms in the onset phase of acute kidney injury. It's when we move down into the oliguric or anuric phase that you're going to start seeing those actual symptoms and assessment changes. So 8 to 14 days, again, each resource you look at may be different, may have a little bit different of a time frame. This is just a very general time frame. About 8 to 14 days after identification that your patient has acute kidney disease, they would be classified as in the oliguric anuric phase. So you're going to be seeing that decrease in urine output, typically less than 400 milliliters a day. You're going to see maybe some hypertension, maybe some increase in fluid volume. Again, if my kidneys are not getting rid of or excreting that urine because I have a low urine output, or I'm becoming oliguric, or even in worst case scenarios, I don't have urine output, so I'm anuric. The fluid, though, we are still taking in. So where is that fluid going? We're becoming edematous, and we're starting to back up. That's why sometimes, which came first, the chicken or the egg? Is it the kidneys or is it the heart? When we look at our patients that have heart failure, it may be relating to the kidneys as well. Hypertension, vasoconstriction, again, we have a lot of fluid. We're still trying to push around the good blood, the blood that's oxygenated, so that we can perfuse all of our organs. But we have so much blood that we have to try to push around because of that hypervolemia. Sometimes in this phase, we may see that metabolic acidosis. So again, if I'm not excreting all of my toxins, I may start having maybe I may see a lactate, maybe I see a buildup of ketones. Again, this is diabetic patient, so we may see that. Potassium, I'm not getting rid of potassium. So we're going to start seeing those electrolyte imbalances. We're going to become very hypervolemic. So we're going to have a lot of fluid, maybe not necessarily a lot of sodium. This could really go both ways with sodium. You could also have a lot of sodium if you're taking in with a really poor diet. You could also have high sodium as well. But a lot of times you're seeing the patients that have high volume or high fluid, low sodium, because we're diluting what our body currently has. So this is typically what you're going to see in the oliguric phase, or that phase 2. Moving up here to phase 3, diuretic. 7 to 14 days after the oliguric phase. So once we identify we've gotten through the oliguric anuric phase, we move into the diuretic phase, which is when our kidneys start to recover. This is the start of the recovery phase. We're not in the recovery phase yet, but we're starting to try to recover from whatever is going on, right? So maybe we've given fluids at this point. Maybe we've given some meds to help correct our electrolyte imbalances. Maybe we've given some diuretics. Maybe we've done some hemodialysis, short-term hemodialysis, and now we're starting to move in that diuretic phase and lessening the load of our kidneys. So diuretic could also take around 7 to 14 days to move into the recovery phase. You're going to start seeing that increase in output again. You'll start to see the GFR move up a little bit, which we'll talk about. You may see your patients start to look a little dehydrated, and their blood pressure they may become a little hypotensive, because if my kidneys are now starting to work and I know I have all this extra fluid, I have to get rid of it somewhere. So I'm going to urinate all of that out, which is going to cause my patient to become sometimes dehydrated, which is why when we initiate IV diuretics, it's super important to just hang really close to that fine line, because if I give too much, I may cause my patient to move into dehydration, and we have a whole nother can of worms that we have to work with. And then moving lastly into the recovery phase can take anywhere from 3 to 12 months. You're going to see that electrolyte balance. Finally, you'll see that GFR normalize, you'll decrease in the edema. So that's typically what you're going to see in the different phases of acute kidney injury. So again, like I was saying, the oliguric phase, oliguria less than 400 milliliters a day. We're going to be looking at what is coming out, what does our urine analysis look like, maybe some metabolic acidosis. Moving down here into our diuretic phase, we start seeing the urine input increase. maybe dehydrated, maybe hypotensive, and then we move down here into the recovery phase. So just again, just a little image to help you guys visualize the different phases. Up here would be before the oliguric phase would be your onset of symptoms. So we've identified now that our patient has acute kidney injury and maybe we can't fix this, right? Maybe there's nothing that we can do at this point. We've tried some hemodialysis, we've tried maybe some medications for electrolyte imbalance, maybe we've tried some fluids, we've tried some diuretics, and we're not really seeing that change. We're going to continue to monitor. Patient may go home, patient may come back and still have that elevated BUN and creatinine. Please remember your BUN and creatinine ranges. I always go by BUN 10 to 20, creatinine 0.7 to 1.4. I know each book, each resource has a different value. Those are just the best ones that I use. Please continue to use whatever values are most comfortable for you. But again, please do remember that your BUN is a little bit more specific to your hydration status and how your kidneys are, not necessarily how your kidneys are functioning, how they're managing with the fluid content, versus your creatinine is very kidney specific. So you're going to be looking more specifically at your creatinine to determine the effectiveness and how your kidneys are functioning. So maybe a period of time has now progressed and our patient has now moved into chronic kidney disease. So let's talk a little bit about GFR or glomerular filtration rate. So how well are our kidneys filtering everything? The higher the number, the better they're functioning. So stage 1 would be kidney damage with normal kidney function. This stage 1 GFR of a 90 or higher would be something you would see on a patient that maybe with acute kidney injury. Maybe you would start seeing stage 2, 89 to 60 GFR with a patient with acute kidney injury. Once we start moving down into stage 3 is when we're starting to see that actual loss of kidney function. So stage 3A is mild to moderate, so a GFR of 59 to 45. Stage 3B is moderate to severe loss of kidney function, 44 to 30% GFR. Stage 4 would be severe loss of kidney function. So this would be your chronic kidney disease stage 4 patients. We see them a lot in clinical. Your GFR somewhere between 29 and 15%. And then kidney failure would be that stage 5, less than 15% GFR. I really liked this little picture down here. I felt like it really helped. Anything really over 60, you're pretty good. Your kidneys are working fine. You're in the green. Anywhere between 60 and 15, you're really looking at problems. And you can really look at this and, categorize this out into 3 little slices, pie slices, right? So mild, or maybe, mild, moderate, severe. Moving down here into the red, anything less than 15 is kidney failure. So becoming just familiar with the different generalized numbers of your GFR will help you be able to identify, how well or how poorly is my patient's kidney functioning. Sometimes too, when we identify our patients have chronic kidney disease, we may do a biopsy. So this is just a nice image for you guys to visualize how a biopsy works. We can use an ultrasound and be able to have direct access into that kidney so that we can have a biopsy. So what are some things that I'm going to assess for my patient? I want to look at a med rec, right? Because I want to make sure, is the patient on any medications that could be toxic or concerning or causing this patient to have these symptoms? So what kind of medications are we really looking at? We're looking at things like metformin. So our diabetic patients taking metformin, this can be nephrotoxic. Things like maybe the patient has chronic pain and they're taking a form of morphine, this can be nephrotoxic. Spironolactone, or really any of your diuretics. Spironolactone is your potassium sparing versus your furosemide, bumetanide, loop diuretics. Both of them can be very toxic to your kidneys. Have they recently had any imaging or procedures that use contrast? These things could all tell me that maybe there's something going on. Also your antibiotics too. So just being aware of what medications may be nephrotoxic. Vital signs. So what do my vital signs look like? Is my patient hypertensive? Do they have a temp? Right? If they have a temp, are they septic? Are their blood pressure maybe low? Are they dehydrated? Maybe they're hypertensive. So just taking a look at those vital signs. What's their output look like? Are they anuric or oliguric, right? Have we already moved into the fact that I'm not having a lot of output? Maybe my urine is cloudy. Maybe I have a lot of protein in my urine or proteinuria. I'm also looking out for my output and my vital signs and I'm looking for maybe some pain along with my vital signs to make sure my patient doesn't have pyelonephritis or bacteria in the kidney, right? So I'm looking for maybe some fever, flank pain, tenderness at the costovertebral angle, maybe some cloudy, maybe urine, maybe there's an odor in the urine. So I may need to initiate some antibiotics, not me, but I may be administering the antibiotics that the provider is ordering. Maybe looking at a weight, relating it heart failure. ABGs, again, my patient's most likely going to be in metabolic acidosis. So because we have diabetes, maybe some antibiotics. Just generally BNP, CBC, are they having an infection? What's their white count look like? What's their sodium, potassium, BUN, creatinine, GFR? So taking a look at that. We could do a renal ultrasound. We could take a look at the kidneys, make sure, see how they look. Do they look enlarged? We could take a biopsy, like I just showed you, to determine the functioning and what do the cells look like. Maybe that can give me a little bit of insight as to what's going on with this patient. Something big, and I made sure I put a star next to this so that you guys remember that this is chronic kidney disease related osteodystrophy. So over a period of time, my body starts to become depleted of my typical electrolytes, right? So my parathyroid hormone or my parathyroid starts to initiate hormones to help with that reabsorption of electrolytes, more specifically within my bones. So sometimes you may see things like calcium, phosphorus, vitamin D deficiencies, which would cause me to have some difficulty with ambulation, maybe some brittle bones. So you may see this osteodystrophy in chronic kidney disease patients and cases. So let's start talking about hemodialysis. So hemodialysis, we need some form of access for. This would be our typical interventions that we would initiate when our patient has acute or chronic kidney disease. Sometimes you may see things like ultrafiltration. We may just be trying to filter the blood. Hemodialysis would be helpful in trying to remove excess amount of fluid, right? So if our kidneys are not working appropriately and they're not able to get rid of the excess fluid, I'm hypervolemic, I need some help. I need something to manually take off that fluid, in which hemodialysis will be really helpful for that. So I need some sort of a access. So I would either have a hemodialysis catheter, right, with our two dual lumen hemodialysis catheter that we only use for hemodialysis, or I may have an arterial venous fistula. So blood comes out, as you can see from my patient's body here, through the roller pump, through the dialyzer, and into a container that holds my waste products and my excess fluid. And then I have nice fresh dialysis fluid, or also called dialysate solution. It runs through the dialyzer as well, and we put nice clean blood back into the body. This clean blood can, or dialysate solution can have electrolytes in it, so we can replete our patient with potassium or magnesium or phosphorus or calcium or anything that they're depleted of. But it is really important to make sure we're watching that electrolyte imbalance. Typically, your acute kidney injury patients or chronic kidney disease patients are going to come in with hyperkalemia, which you'll see on my little paper that I wrote, up and a down for potassium, because you're going to see hyperkalemia when they come in, but you're going to see hypokalemia once you start treatment, right? So if I give them a loop diuretic, or if I do hemodialysis, or even peritoneal dialysis or CRRT, I'm going to see that depletion of that potassium. So I'm going to want to watch out for that. I'm going to want to monitor their EKG or your tele to make sure I'm not having any peak T waves in relation to that hyperkalemia, and then that depression, that ST depression from hypokalemia. Remember, potassium is 3.5 to 5. We may deplete phosphorus. We may deplete calcium, as I was talking about earlier, which is why our parathyroid hormones start to kick in. We're going to start we may deplete our patient too much of fluid, so they may become dehydrated, may take out sodium, I may take out a little too much magnesium. So you may see some of those electrolyte imbalances as well. I am going to want to make sure that during this time of hemodialysis, I'm watching my patient at all times, because I do not want them to become symptomatic. If for some reason my patient did become symptomatic, so dizziness, lightheadedness, maybe some shortness of breath, maybe I see a decrease in the blood pressure, continuous low. You know, I'm starting them out at 130 over 90, 140 over 90, and now we're moving into like 90 over 50, 90 over 40, 80 over 40. We're going to start to slow down that treatment. Maybe it's just too fast. Typically, we run hemodialysis over 4 hours, but sometimes you'll see your patients are there for a longer period of time, because we have to make sure that we slow that treatment so that it can still be effective and we can do as much as we possibly can. So first chain of command, assess the patient, slow down the treatment, and then obviously if that's does not work and slowing the treatment down is not effective, then we would stop treatment at that point. Like I said, we would monitor our telemetry, look out for our T waves or ST segment, monitor our temperature. Again, we could be possibly removing a significant amount of fluid. Sometimes our patients, we can remove 2 to 3, even at sometimes I've seen 4 liters of fluid removed during hemodialysis. So we want to make sure that we're just watching that and they're not becoming, you know, they're not, we want to make sure that they're not febrile when we're starting the hemodialysis, because maybe there's some infection brewing, but we also want to look at their temperature post hemodialysis as well. Moving into peritoneal dialysis. Let me just show you peritoneal dialysis. Big thing to remember with peritoneal dialysis, it is not an option if your patient has had any severe abdominal surgeries. Again, if we have manipulated this whole area over here, this is not necessarily going to be effective. So no peritoneal dialysis if your patient has had abdominal surgery or any adhesions as well. So what is peritoneal dialysis? We have a dialysate bag that's full of nice new dialysate solution that we're going to put in, or what we call instill into the patient through this little catheter into our peritoneal cavity. And then we have this nice drainage bag, which is going to take out the old dialysate solution. Let me see how I can. All right. So what happens first? The first thing to always remember is, first of all, we're going to assess this site. Right, so we're going to have some sort of a tube connecting to my patient. I want to make sure that this incision site for my peritoneal, my catheter is clean, dry, intact, not red, not swollen, not tender. I want to make sure that this looks wonderful before I attach my patient to this. Number 2, I'm going to make sure that I am sterile in connecting this device. This has to be sterile. It is directly into the patient. Sterile gloves, You don't touch it. The biggest risk factor is peritonitis. So that's why it's sterile. Sometimes there are little caps that utilize different medications to help maintain sterility of this little catheter, which you can actually see right over here. This is one component. So I'll show you guys this in class. You get two bags. One has the dialysate in it. One is empty. They come in here at a Y site, and this is the area that you would connect to the catheter. So number one, connect your patient, assess your patient. Number two, connect your patient. Number three, break your drainage cap. So usually there's a little device in here that you have to snap open, and you are draining first. Why are you draining first? Unless this is the first time the patient has ever in their entire life had peritoneal dialysis, and this is a post-procedure patient just came up, you will, first time only, you will put in, or you will instill dialysate first. Every time after the first time, you are always draining, which is why it's so important to remember you are draining first, because your peritoneal cavity or your peritoneum already has solution in it. You can't put in new solution with it full of old solution. So we're going to drain first. So typically your patient is going to be laying in the bed, maybe sitting up on the edge of the bed. You're going to crack this little area open for the drainage bag. I usually lay a nice white towel onto the floor, and then I lay the drainage bag on top of it. The drainage bag is it's cloudy to begin with, and it looks similar to an IV bag. So I lay a nice white towel down first. I know that that's clean. The towel's clean. It's not laying on the floor. That's dirty. Risk of infection. Two, it gives me a nice white background, so I can actually see what color the solution coming out of the catheter or out of your peritoneal cavity is. If your peritoneal your solution coming out of your peritoneum into your drainage bag is amber, orange, cloudy, maybe you see particles, you are definitely needing to notify the provider immediately because your patient most likely has peritonitis. So an inflammation of your peritoneum or your peritoneal cavity. So starting over. Assess your patient first. Hook up your catheter to your bags second. Drain completely. Takes about 10, 15, maybe 20 minutes. You always want to look at how much was put in before so that your intake and output is the same, right? So if I put in maybe a liter 4 hours ago, I'm hoping to get close to a liter out. Sometimes you may have to reposition your patient. Maybe they have to lay on the side that the catheter is on. Usually your catheter is not midline. It's usually on one side or the other. You may have to lay on that side. Drain your bag, clamp this. So clamp this as number 4 when you've drained. And then crack this and give your dialysate solution. So your dialysate solution, typically there's a lot of different dialysate solutions. A lot of times it's a hypertonic solution to help give or allow your body to utilize the nutrients that are going to be in the dialysate solution. Usually we give anywhere between 1 to 2 liters of dialysate, and we infuse it over 15 to 20 minutes. Always make sure that it's at least room temperature or warmer. If it's cold, it can just cause a lot of abdominal cramping and pain and a lot of discomfort. So we try to warm it to body temperature so that it's comfortable. You can give it with a dialyzer, or you can administer it manually. So in the hospital, we always administer it manually. Patients at home will have a dialyzer, and they will hook themselves up before they go to bed, and they'll dialyze all night, and then they'll unhook themselves during the day. This is the primary solution for a lot of our patients that don't want to go to hemodialysis, Monday, Wednesday, Friday, Tuesday, Thursday, Saturday, and want to still work and still are capable of doing something like this at home. So the patient will go home and be able to dialyze at night and then go to work the next day and then come home and dialyze themselves at night and still be able to have a very active, positive quality of life. What did I miss? Like I said, always want to make sure that you're looking at the drainage coming out. Your drainage is called effluent, so you want to make sure that that's not clear, or you want to make sure it's clear and not cloudy or amber or dark in color. Always assess, you're always going to assess vitals before and after. No abdominal surgeries. And if it's manually and we're doing it in the hospital, you're typically doing it on a schedule. So maybe we're going to do it 4 times a day. So if I'm doing it 4 times a day, I'm going to do it every 6 hours to 6 hours. Maybe they want you to do it 6 times a day. So every 4 hours. So it just really depends on what's necessary. Typically, you hang the bag and measure the weight of the bag of the dialysate solution you're putting in, and you measure the bag of effluent or drained solution so that you can continuously monitor that intake and output and know if there's, is the patient holding on to a lot of fluid still? Maybe you put in 2 liters and you only took out 1.5 the next time. That's concerning, because if every time I'm holding on to 500 milliliters or half a liter of fluid, that's not really helping my problem. So I need to look at that. And we'll talk about this a little bit more in class as well. I'll show you physically what this looks like. CRRT, basically connected to hemodialysis. They are essentially the same thing. The only difference, continuous renal replacement therapy, or CRRT. Less stress on the heart and it's slower. So it is the same functioning and setup as hemodialysis. It's really doing the same thing, except with hemodialysis, we're doing this over like 3, 4, 5 hours. Continuous renal replacement therapy is right in the beginning of the name. It's continuously. So we can do it really slow. It doesn't stress your heart, it doesn't stress your kidneys. A lot of times we're doing this because of failed treatment. So I've tried hemodialysis and it just was not successful. Maybe I have full body edema, I have anasarca, and no treatment is really affecting this. Maybe I have, again, fluid volume overload, metabolic acidosis. Maybe all of these extra toxins are causing me to have encephalopathy. There's something else going on. Maybe I'm in septic shock and we start continuous renal replacement therapy. Maybe I have heart failure and I have a SWAN and I need to start continuous renal replacement therapy. So this would be really what you're going to see in ICU settings for your patients that are higher risk and, very sick, very acute patients. The only thing to make sure of remembering for continuous renal, for any of these dialysis solution or dialysis treatments and interventions is you're not necessarily administering any of your medications prior to this, because most of your medications will be dialyzed out. So say I give blood pressure medication and then my patient goes to hemodialysis 30 minutes later, I may not see the effects of that blood pressure medication work. There is actually a whole manual that will actually go through and tell you what medications will be dialyzed out of the system. Usually your dialysis tech has access to all this information. If you are in clinical, you would never be asked any of these kinds of questions on your NCLEX or on the test or anything like that, but just something to keep in mind. Sometimes your patients that are being dialyzed need some form of a anticoagulant as well. Again, if they're at risk for bleeding, maybe your patient has heart failure with AFib, and sometimes we can administer anticoagulation or heparin during these solutions or during these interventions as well. And then last intervention is down here, kidney transplant. So it's not necessarily exactly what you think. We're not necessarily taking out and putting a new one in place of your old ones. If you look here, we have a donor, we take out the donor kidney and we transplant it right down here, and it's kind of bypassing the whole situation. We have our 2 diseased kidneys. We're not taking these out and then putting new ones where those were. We're just adding the other one in. Postoperatively, your care is going to be the same as every other post-op patient. You know, you're going to be monitoring for vitals and ambulating and fluids and site assessment to make sure that there is no risk for infection. Big things though to remember are what to look out for if your body is if your patient's body is rejecting the kidney, right? So we hear this a lot about rejection. We read about this a lot. So things to look out for. You're going to look out for increased creatinine, right? So increased stress. My kidneys are not functioning, working the best anymore. Febrile, right? So my patient has a fever. Maybe they have some infection, some flu-like symptoms. I'm going to start seeing that edema, maybe some pain, some decreased urine output, maybe an increase of weight. What do all these sound like? Acute kidney injury. So you're really seeing collaboration of acute kidney injury symptoms and fever and sepsis infection. So, or sepsis symptoms combining, and that's really going to be your rejection. That's typically what you're going to see within 3 to 6 months after. At most, you're not necessarily going to be seeing a patient that had a kidney transplant and it was rejected like 5 years later. This is something typically in the acute phase. And sometimes it can take your body a period of time to reject that. It's not necessarily within the first 24 hours after surgery. They do typically do a biopsy about 3 to 6 months after as well, just to check and see how your kidney is working and your new transplanted kidney is working, and assess the cells. Sometimes they'll compare them to the diseased kidneys. And what are some medications that you're going to see? You're going to see some antibiotics, some steroids, and some anti-rejection medications. So things like prednisone as your steroid. We have cyclosporine antibiotic, and then we have your Rapamune and your mycophenolate, or your mycophenolate is your Cellcept, which will help with preventing that rejection from happening. So what am I going to do to discharge my patient after they've had a kidney transplant? I'm going to teach them all about diet. I definitely want to make sure that they're washing their hands and performing hand hygiene. They're looking at their incision site so that everything looks good. Wash your hands. Make sure that you're taking your medications regularly. And then just teaching them about what the symptoms are if they are having any rejection of that kidney. Some other interventions that I don't have up on the screen that you would want to look out for, or some things other than, you know, hemodialysis, peritoneal dialysis, any form of dialysis or a kidney transplant. You may also see some other interventions relating to maybe some fluids. So you may see some initiation of fluids during this period of time. Yes, our kidneys are maybe holding on to fluid, and we're a little, we have some edema or edematous, but we may initiate some fluid to help with perfusion of our kidneys. We may also see our patients administer diuretics, so things like furosemide, bumetanide, to help with diuresis and getting rid of the extra fluid. We may give some calcium channel blockers to help reduce that blood pressure, especially if our patient is hypertensive. We also may see some potassium replacement in our patients here as well. If your patient comes in with hyperkalemia, there are some definitely big things that we want to watch out for. So your patient that comes in with hyperkalemia, I'll actually add another slide because I definitely did not add that on here. So high potassium, and maybe they're not going for hemodialysis. So what kind of treatment can we give our patient that has hyperkalemia, or say greater than 5? We can start off with number 1, calcium gluconate. It helps stabilize your cardiac cells. right? So we know that potassium and our heart are super important, and it's a huge link together. So I want to make sure that before I try to get rid of all of this extra potassium in my patient's body, I don't want to cause my patient to have any dysrhythmias or any chest pain or cardiac related problems. So I'm going to give them some calcium gluconate first. And then as long as everything looks good with their tele and EKG, I'm going to give them dextrose or B50 and in regular insulin. The insulin shifts your potassium into the cell, so that way we can get rid of all of the extra potassium. However, we also know that insulin reduces your blood sugar. So that's why we're going to give the dextrose. So dextrose is solely only given for stabilizing our glucose while we're administering insulin. We're administering this IV, insulin IV, not sub-Q. So it's a very small dose. As we don't necessarily do this in regular practice. Our patients that are diabetics are not coming in and we're starting them on insulin and their IV. We're giving them sub-Q, but we want this to work fairly quickly. So we're going to use the insulin to shift K into cells, and we're using dextrose to stabilize our glucose due to use of insulin. Some other treatments that we can do, we could give K-xylate, which will cause us to have a significant amount of diarrhea and therefore will remove potassium. In this case, I want to obviously watch and make sure that they're not doing, they're not becoming hypokalemic. So we're going to watch Kelly. But this works over a longer period of time. The calcium gluconate, the dextrose 50, or some form of dextrose and regular insulin is going to be really quick. It's going to help shift that and get rid of it really quickly. And then lastly, hemodialysis. So big things just to remember for your patients that are coming in with hyperkalemia. If you guys have any questions at all, please feel free to reach out to me. Otherwise, this is the lecture on acute and chronic kidney disease.